Greetings to the staff of the greatest ILC on earth, the Kent Northwest Kidney Center. Once again, we come together virtually doing a video in service because of the COVID pandemic. This will hopefully be the last in a series of 4 talks on the COVID-19 pandemic. I say the last one because it appears that we have passed the peak of the pandemic, and I anticipate that the quarantine will end in the near future. Hopefully we can have an in-person in-service next month on some happy topics such as volume status or hypertension. Before I begin, I want to thank you for watching last month's video. On the one hand, I was pleased with the fact that there were over 40 views of the talk. On the other hand, the video was unfortunately assigned only 2 likes. So let me help you with the math. 2 out of 40 is 5%. And I think that my daughter was one of the likes and one of my office partners, Dr. Mukherjee, was the other. Now, I'm not asking you outright to like this video, although I don't think that it is unreasonable that you consider lowering your standards and expectations. If you expect this to be a low quality talk and then are pleasantly surprised that you glean maybe 1 or 2 facts from it and earn 30 minutes of CME in the process, I think that alone is justification for liking the video. Also in advance, I want to thank my producer, lighting manager, makeup artist, wardrobe consultant, content advisor, etc., my 11-year-old daughter, Jeannie. Without her, this video would not have been possible. So let's begin. This talk has 3 objectives. Over the last few months, we've learned a great deal about the novel COVID-19 pathogen, and I will review updated facts and features of the SARS-CoV-2 virus. Additionally, the experience of enduring a pandemic infection has revealed several insights regarding our society and our global community, which we'll discuss. And finally, we'll briefly talk about the models that predicted the clinical course of the pandemic and why the severity of the infection was not as bad as expected. So let's begin with a summary of updated facts regarding the COVID-19 infection. For starters, there are 3 types of SARS-CoV-2 virus. Type A virus is a strain that jumped from bats to humans, probably via pangolins, these anteater creatures, as an intermediate. 2/3 of the infections in the United States are caused by the type A virus. Type B is derived from type A via 2 mutations and is the variant that was most common in Wuhan. It is also the strain that is most common in Europe. Type C coronavirus strain is also common in some places such as Europe as well as Asia, specifically in Singapore. This strain is the daughter of type B and is just 1 mutation different from it. So the first documented case of COVID-19 infection occurred in November 2019 in Wuhan, China. Since then, there have been more than 2.7 million confirmed cases reported across 185 countries and territories, resulting in more than 200,000 deaths worldwide. Just to put it in perspective, the Spanish flu of 1918 resulted in more than 50 million people being infected, 500 million people infected, and the death total was probably somewhere between 50 and 100 million. Most symptoms are respiratory in nature. So in addition to fever, people present with cough and shortness of breath. Muscle pain and gastrointestinal symptoms such as diarrhea and abdominal pain occur, although are less common. While the majority of cases result in mild symptoms, some progress to pneumonia and multi-organ failure. Many, however, remain completely asymptomatic. So what is the prevalence of asymptomatic infection? This has been looked at in several studies. To start with, Life Center in Kirkland, the former epicenter of infection here in the Pacific Northwest, 15% of patients who tested positive were found to be asymptomatic. You'll remember the Diamond Princess cruise ship that was docked outside of Yokohama, Japan for several weeks. Of the 634 guests who tested positive, 18% were asymptomatic. In a hospital in South Korea, 20% of patients who tested positive were asymptomatic. In a Tibetan population in Daofu County, 22% of patients tested positive, had no symptoms. 31% of Japanese nationals evacuated from Wuhan were asymptomatic. In Iceland, 50% of those who have tested positive had no symptoms. And in one study of 60 asymptomatic volunteer blood donors, 2/3 of those patients who tested positive had no symptoms. So, we all know that COVID-19 virus spreads via droplet, small droplets produced by coughing, sneezing, or talking. And we all try to maintain 6 feet of social distancing when in public, although an inconvenient fact is that a cough can spread the droplets up to 15 feet. We also know that the virus can spread by touch contamination. If you touch a contaminated surface and then rub your eyes or touch your mouth or nose, you can inoculate yourself with the virus. But a lingering question that people are concerned about is the virus airborne? The virus is considered airborne if it can be transported in aerosols smaller than 5 micrometers in diameter. The small aerosols can travel long distances in the air. In contrast, heavier droplets travel relatively short distances after coughs and sneezes. Aerosols are more likely to be produced by talking and breathing, and therefore an asymptomatic carrier can transmit the infection just by breathing in the same space as other people. There is growing evidence that the COVID-19 virus can be transmitted in an airborne fashion. In a study performed in Wuhan, during the Wuhan outbreak, a virologist at Wuhan University collected samples of aerosols in and around hospitals, treating people with the COVID-19 infection, as well as at busy entrances of 2 department stores. And they found SARS-CoV-2 viral RNA in a number of locations, including in front of the department stores. University of Nebraska did a recent study looking at 13 patients who had confirmed positive infection. The authors collected air and surface samples and basically found that there was evidence of viral shedding, not only on contact surfaces as well as restroom facilities, but also within air samples. So the authors conclude that airborne isolation precautions should be followed with the infection. This is another inconvenient fact that we have not embraced in the management of this infection in this country because of the limited availability of isolation rooms, including in dialysis units. So, airborne precautions are recommended with this infection. Okay, so how long can the virus live on inanimate surfaces? So only about 4 hours on copper surface is why I've replaced everything in my house, from the furniture to the fixtures to my bed, to pure copper. And it's worked because I've stayed healthy through the pandemic. Additionally, the virus has been shown to survive for 1 day on cardboard surface. So it's unlikely that you will get the infection, say, from an Amazon package. In contrast, it's been demonstrated to survive for 3 days on plastic and 3 days on stainless steel surfaces. So wiping down these surfaces is a really good idea. Okay, what's the incubation period of the virus? Well, the typical incubation period is 5 to 6 days. Nearly 90% of people will develop symptoms, or I'm sorry, 97% of patients will develop symptoms within 11 days of infection. So, hence the origin of the recommendation of a 2-week quarantine for those with a history of exposure or recent travel. Okay, so how is the virus diagnosed? The standard method is real-time reverse transcription polymerase chain reaction, or PCR, from a nasopharyngeal swab. Notice in the photo how deep the swab is inserted. It's a very uncomfortable collection procedure. But if you don't do it correctly, it's possible to obtain an insufficient sample and therefore miss the diagnosis of infection by PCR. In the near future, we should have antibody testing available, and will likely be employed on a broad schedule as a way of detecting people who have already been exposed. Antibody testing indicates past exposure but does not necessarily confer immunity. There have been several cases in the literature of people developing a second case of COVID-19 infection. So just because you produce antibodies against the virus doesn't necessarily mean that you are immune to it. Okay, so mask use. Should we wear masks? So this is a source of probably unnecessary controversy. The World Health Organization currently recommends mask use only if someone is coughing or sneezing, or if you're taking care of someone with suspected infection. In January of this year, the CDC recommended similar guidelines for medical professionals and patients who are acutely ill. But in April of this year, they began recommending the public use of cloth coverings for their mouths and noses when leaving the home. Northwest Kidney Center has basically adopted the CDC recommendations. Initially, no masks were recommended, and now they recommend staff and wear masks and patients wear masks if they have any symptoms. So why the confusion? Why not just masks for everyone? Well, in part it reflects insufficient evidence for or against the use of masks in the general population, that is, in the community. But probably the biggest factor is the fact that mask recommendation for the general population may limit the availability for healthcare providers and for patients. Okay, treatment. Treatment for the COVID-19 infection is largely supportive. If you listen to the news, many treatments have been touted as successful breakthroughs. Some are being studied, while others are really anecdotal or ineffective, sometimes put forth as a financial opportunity for people who are selling those treatments. Okay, one such combination that has been recommended by President Trump and therefore gained a lot of media attention is the combination of hydroxychloroquine and azithromycin. Hydroxychloroquine is an anti-malarial drug. It's also used to treat autoimmune diseases such as lupus. Azithromycin is a commonly used macrolide antibiotic. Most often it's used for upper respiratory tract infections. So there have been a couple of studies that have looked at the combination of hydroxychloroquine and azathioprine. The first one was a French study. It was an open-label, non-randomized trial in France looking at hydroxychloroquine and azithromycin in 28 patients with COVID-19 infection. Basically, 22 had upper respiratory tract symptoms, and 8 had pneumonia, and 20 were randomized to hydroxychloroquine and azithromycin. Basically, they found that the duration of infection was shorter with hydroxychloroquine, and shorter yet in the combination of hydroxychloroquine and azithromycin. Admittedly, the study was a small sample, and this was a non-randomized study, but still it was suggestive and provocative. More recently, just published in the past week, was a study out of the VA system in South Carolina. Basically, it was a retrospective study of COVID-positive patients treated in the VA healthcare system. They looked at 368 COVID-positive patients. 97 of them were sick enough to receive hydroxychloroquine and azithromycin empirically. And in this study, there's actually a higher death rate among the hydroxychloroquine group. The major problem with this study is it's not a randomized study. There is the potential for confounding. That is, the sicker patients were much more likely to receive more aggressive treatment, including hydroxychloroquine and azithromycin. Okay, Remdesivir is an antiviral medication developed by Gilead Sciences, which is an American pharmaceutical company. It was originally developed about 6 or 7 years ago as a treatment for the Ebola virus. There are ongoing randomized controlled trials for the treatment of the COVID-19 infection, and all those stem from the fact that it was first used empirically in an Everett man who was hospitalized with the coronavirus. Basically, he came in with worsening pneumonia, his oxygenations declined over a 4-day period, he had high fever, and doctors subsequently treated him empirically with remdesivir, and within 48 hours his condition improved to the point that he was ready for hospital discharge. So it was quite a dramatic turnaround. In March of 2020, there was a small trial of remdesivir in rhesus macaque monkeys with COVID-19 infections, found that it prevented disease progression. The drug was available for recent compassionate use for people with COVID-19, although this was stopped because of short supply of the medication in March of 2020. So now the medication is only available as part of research trials. Okay, now, interesting, there are many ineffective treatments that have been touted in the media and online, often by people in positions of authority. Vitamin D and vitamin C have been suggested for a long time for various infections, but there's no evidence at this point that either is effective in treating COVID infections. There is, however, an ongoing randomized trial of vitamin D in COVID-positive patients. There's no evidence that sunlight helps fight the COVID infection. Gargling salt water has not helped. Basically, there was a theory circulated early on that coronavirus stays in the throat for a few days before making its way into the lungs. And to counter that, some people have suggested gargling with salt water or vinegar. Maybe you could wash the virus out of your throat, preventing it from taking hold or going down into your lungs. That is not true. Volcanic ash has been suggested as a way to kill the virus. Basically, that stemmed from the false claim that the volcanic eruption in the Philippines in January of this year had decreased the burden of disease in that country. And there's no evidence that volcanic ash prevents or treats COVID infection. Special toothpaste has been suggested to fight infection. Various herbal medications have been used, including in China, and there are no data to support their use. Alcohol, no evidence of alcohol prevents or treats COVID. One type of alcohol is methanol. Methanol is basically a type of alcohol that's used as an industrial chemical and as a fuel source. It's definitely toxic to humans. It's converted to formaldehyde in the body, which can lead to brain damage, death, and blindness. And in Iran, in March and April of this year, basically over 600 people had died and 3,000 hospitalized from methanol poisoning. Again, this idea that methanol could somehow prevent or treat the infection became known or public in Iran, and people drank it and died. Okay, cow and camel urine has been touted in the Arabian Peninsula basically as treatment for COVID infection. Basically, camel urine has been used in the Arab world for medicinal and religious purposes for centuries. And some Iranians have been drinking it on a regular routine to prevent or cure COVID-19. Not only is it ineffective, but it's gross. You can actually get diseases from drinking camel urine, including viral infections. Various fruits have been suggested to have healing power. At the least, the smell of durian is bad enough to keep people 6 feet away from you while you eat it. That might help prevent the COVID infection. Ice cream. I couldn't figure out how ice cream made the list of potential COVID treatments. Probably some young person with computer skills entered into the internet and it took hold. And finally, this is a poster advertising onions as prevention for influenza during the 1918 influenza pandemic. Onions are still being touted as a potential cure and treatment for the COVID infection today. Okay, so let's now talk about what we've learned about society, both local and global, from the COVID-19 pandemic. First, we've learned that at every level of our society, from the federal government to the state government to King County, to our school systems, hospitals, even dialysis units, we've been ill prepared for a global pandemic. In retrospect, this isn't a surprise. In fact, in 2019, the Global Health Survey, which is basically a collaborative project of Johns Hopkins Medical Center, the Nuclear Threat Initiative, and the Economist Intelligence Unit, basically created a preparedness index for a potential pandemic, and they published the results in October of 2019, not long before the current pandemic actually became reality. And the conclusion was that the world is wholly unprepared for to handle a global pandemic. They rated 195 countries according to a global health survey index, and the average score was 40 out of a possible total score of 100. The 60 highest income countries averaged a score of only 51.9, and there were several areas identified for improvement. First, most countries lack an ability to prevent, detect, or respond to health emergencies on a large scale. We've seen that here in the United States. Second, there are multiple vulnerabilities in most countries, including political and socio-economic factors that basically confound the country's ability to respond to an outbreak. And additionally, there's no international norm to which countries can adhere to or aspire in managing a pandemic. The second thing that we've learned about society is that there are numerous heartwarming stories about how the global community has come together to effect significant change to help one another. Basically, healthcare workers have shown incredible commitment to their communities, including our wonderful Kent dialysis unit. Neighbors have organized support for vulnerable people, people buying groceries for elderly neighbors, supermarket workers have worked long hours to stock groceries. Businesses and national governments have stepped up to provide support for those who need it, strengthen basically Social Security and health services. And there are lots of examples of international solidarity, basically the sharing of resources, information, expertise around from other countries. This is a list of international companies, for example, that have come together to help out the global community fight the pandemic. Airbus, for example, has repurposed a bunch of 3D printers to produce thousands of visor frames to make protective face masks. AB InBev, basically a leading global brewer, has produced disinfectant alcohol in hand sanitizer, more than 1 million bottles produced from their alcohol. Unilever is the world's biggest soap company. They've donated free sanitizer, soap, bleach, and food worth over 100 million euros to the world's neediest. GlaxoSmithKline and Sanofi, basically two of the world's largest vaccine manufacturers, are collaborating on a COVID-19 vaccine. Coca-Cola has redeployed resources to making face shields. Pepsi company has donated 45 million to basically various COVID-19 relief efforts. Lego Foundation donated $50 million for continuing child education. Procter & Gamble has produced more than 45,000 liters of hand sanitizer per week, and most of this goes to hospitals and relief organizations. Google has pledged $800 million to support businesses, governments, healthcare workers in the fight against COVID-19. Apple has donated 10 million masks to the United States and millions more to European countries. And basically the list goes on. So there's been really tremendous outpouring of goodwill by individuals as well as companies. Very heartwarming. Okay, lesson number 3, people are willing to quarantine. This was news to me. There was basically a recent poll, a political poll of 2,000 voters. It revealed that a whopping 74% of Americans support national quarantine. It's really remarkable. 40% of registered voters say they strongly support national quarantine, 34% say they somewhat support the idea, and only 19% have been opposed to it. So this is something I never would have imagined people would be willing to do. I never would have imagined it would be willing to, or that people would be accepting of closing schools for 6 months, for example. Okay, lesson number 4, traffic is a lot better during a quarantine when people stay at home. There was a UC Davis survey that showed during the quarantine period over the last couple of months that there's been a 50% reduction in motor vehicle collisions. In California alone, there have been 15,000 fewer collisions per month and 6,000 fewer injury accidents per month. There's been a 60% drop in traffic volume. And not surprisingly, oil demand has plummeted by 20%. Oil prices have fallen precipitously during this period. We also learned that working at home is a viable option for many workers. This may be good not only for the workers, but for companies, for traffic, for pollution, and I hope that this actually persists beyond the quarantine. It's interesting, we spend billions of dollars building sound transit, widening roads, etc., when the solution to our traffic congestion problem may be solved with technology and not construction. As an aside, while I think that workers should work at home if possible, I think school at home is a terrible idea and that kids need to return to school immediately. Okay, the last part of the talk, we'll briefly discuss where the COVID-19 models went wrong. So specifically, why did they overpredict the extent and the severity of the illness that we would see? Okay, so, in an effort to predict the potential impact of the COVID pandemic, many scientists developed models that estimated the course of the infection over time. And most of these models overestimated the extent and severity of infection. In a way, this is important because the numbers were alarming, and this may have contributed to panic among the general population, as well as provided incorrect information for policymakers. So what did the models predict? Well, there were lots and lots of models. Some that were featured prominently in the media included the Imperial College of London, which predicted as many as 500,000 deaths in the United Kingdom and 2.2 million deaths in the United States. Our very own University of Washington predicted as many as 162,000 deaths in the United States and 66,000 deaths in the UK. So why were the models wrong? Well, first, models require an input of quality data. And if the data you have are inaccurate, then the model will be inaccurate. Much of the early data relied on the Chinese experience, and there's reasonable concern that the information from China was inaccurate. So, for example, a recent study of COVID-19 cases in Wuhan, China, estimated that the death rate among people who were infected and developed symptoms was 1.4%, and that's far lower than the crude fatality rate that you get by dividing the total number of deaths by the confirmed cases. That was 4.5%. And the World Health Organization also had their own crude fatality rate calculated of 3.4%. So the actual fatality rate is much lower than that. So if we had had that information early on, then the models would have more accurately predicted the number of deaths. There's an expression in modeling, garbage in equals garbage out. So you need to have good quality data in order to have a good quality prediction. Okay, it's also difficult to factor in elements such as social distancing and the impact of quarantine. Additionally, it's probably better for models to over-predict the severity of a pandemic than to under-predict it. It encourages us to prepare for the worst case scenario. In the words of Bill Gates, I hope it's not that bad, but we should assume it will be until we know otherwise. Okay, time for the dreaded part of the talk, quiz time. What is the prevalence of asymptomatic COVID-19 infection? Give you a second here. Feel free to press pause on your YouTube screen. Right, 15 to 67%. So, upwards of 50% or two-thirds of patients have the potential to be asymptomatic with this infection. How far can droplets travel with a cough? You got it, 15 feet. That is, by the way, the length of this python that was harvested from the Florida Everglades. Is there evidence that COVID-19 infection can be airborne? And survey says yes. So we should probably be taking airborne precautions. The models predicted more deaths than observed. Why is this? One, probably better to assume the worst so that you prepare for the worst, not for the wart, but for the worst. And we had limited or inaccurate data available early on in the COVID-19 infection. Thank you very much for your attention. Stay safe. Bye-bye.